2 weeks ago, Frank was brought to the emergency department by his wife, complaining of an unbearable headache, slurred speech, and loss of control on his left side. He was admitted to the acute care hospital and was stabilized. After 5 days, he was transferred to the rehabilitation hospital for more extensive therapy. His expected length of stay is 3 weeks. Frank is a 68-year-old white male. He's a retired postal worker and enjoys traveling with his wife, gardening, and woodworking. Frank has a strained relationship with his son from a previous marriage who does not live nearby. Frank lives with his wife in a rural neighborhood, and there are 5 steps into the front door of their home. Frank suffered a right CVA of the internal carotid artery with left neglect. He also has coronary artery disease and diabetes. During Frank's rehab stay, we would focus on ADLs, leisure activities, and social participation. We would focus on ADLs such as bathing and dressing because these are areas that were reported as problematic. We would also focus on leisure activities because him and his wife's goal is for him to return home and resume his hobbies, and we always want to consider our clients' desired outcomes. Some self-care deficits likely to affect his rehab are his left neglect, his poor safety awareness, and impaired sensation. The poor safety awareness and impaired sensation could be a problem when addressing bathing and dealing with warm water or shaving. He's also experiencing dressing apraxia, which is making clothing management more difficult. Knowing that Frank enjoys gardening and bowling, we would incorporate these into his intervention plan. We could do an activity with making a potted plant while seated at the table. We could use this to address his left neglect, work on releasing objects, and right-left discrimination. We could also use gardening tools to help work on figure ground and spatial relations. We could also do a modified bowling activity with small bowling pins and a foam ball to also address the left neglect. Frank is a husband, a retired postal worker, a father, a friend, and a bowling team member. Since his CVA, his role as a friend has been changed because he can no longer attend weekly bowling nights with his post office friends. Prior to the CVA, his wife did most of the chores in the home, and she has expressed her willingness to do whatever it takes to get him home. In order to help facilitate Frank's role as a friend, his wife could help transport him to and from weekly bowling nights. We could also provide Frank with some adaptive equipment to help him with his gardening and bowling to maintain his role as a member of his bowling team. The picture on the right is an example of an adapted bowling ramp that Frank could use on bowling nights to help maintain his role as a bowling team member. Prior to his CVA, he attended weekly bowling nights with his postal worker friends. Frank is also used to doing all the maintenance tasks in the home as well as helping his wife grocery shop on occasion. He enjoys spending his free time tending to his garden and woodworking. These routines will most likely be affected by the CVA and will have to be modified. Having his wife around to help him will be a big part of Frank's recovery. She's used to doing the chores around the home, but she will have to help Frank in maintaining his routines as he recovers. Some performance skills that are negatively affected by Frank's CVA are coordination, walking, attending, stabilizing, manipulating, navigating, positioning, accommodating, reaching, and turning towards. And some performance skills that are strengths are acknowledging, heeding, benefiting, moving, sequencing, terminating, continuing, approaching, organizing, and transitioning. So in order to get Frank set up at the sink to bathe, we would have him seated in a chair with armrests in front of a mirror. We would place any items that he needed on his left side to address his left neglect. Frank will require a lot of verbal cues to accomplish the task as stated in the case study, and he may also require hand-over-hand assistance to accomplish the task.
So in sending Frank home, we would want him to have a Hemi walker since that's what he was using while in rehab. Additionally, things such as a long-handled scrub brush to use in the shower, sock aid and shoehorn would be inexpensive items that could be supplied to him. There are lots of items that could be recommended for Frank to purchase on his own. For bathing and toileting, a shower chair, grab bars, and non-slip mat for in the tub would be suggested. Additionally, items such as a one-handed cutting board and using Dyson under his plate when eating would be useful when he is in the kitchen. To address the issues Frank is having with his ADLs due to left neglect, we would start off by helping Frank to develop an awareness that this issue even exists. After that has been established, the visual imagery technique called the lighthouse strategy could then be employed. Frank would be taught that whenever he needs to search for something, he should imagine being a lighthouse, like the picture provided to him, and to always scan widely from left to right. Frank would be cued to look at the picture and imagine being the lighthouse before completing an activity. This technique is implemented during all of Frank's treatment sessions. Since he likes to cook breakfast for his wife and cooks for himself on occasion, a terrific functional activity would be to have Frank practice using the technique in the kitchen, where he will have to search broadly for the food and cooking items necessary to prepare the meal. An important aspect to addressing neglect is to use a multi-context treatment approach. The more often that the visual scanning technique is repeated in a different circumstance, the more readily the skill is generalized and transferred to new situations. As Frank progresses, his sessions can include him going to the hospital gift shop or cafeteria and having to do some kind of visual scanning activity there. Some other activities an OT could do with Frank include using a Dynavision or playing games such as solitaire that require the head to move from left to right. To address Frank's dressing apraxia, we would work together to problem-solve effective dressing strategies. Examples could be that he positioned the clothes the same way each time he goes to put them on, and that he used labels or buttons to differentiate the front from the back of his garments. We would send Frank home with a morning routine handout that he could keep on his bedside table and refer to when he first gets up. Items on the handout include reminders for him to brush his teeth and to use his tub bench and grab bars in the shower when bathing. We would have discussed with his wife the helpfulness of rearranging Frank's closet so that it would be easier for him to get dressed in the morning. So we will include the reminder that his shirts are on the right side of the closet and his pants are on the left. Additionally, the handout reminds him that the labels on his clothes signify which side is the back of the garment. We'll also attach some additional dressing technique handouts for quick reference. When he goes to make breakfast, the handout also reminds him to always turn off the stove when he is done using it. We think Frank making breakfast for his wife would be a terrific intervention activity to work on with him. It is both functional and meaningful. However, the activity would definitely need to be graded, especially since Frank is having issues with safety awareness. Frank typically would make toast and coffee for his wife, but a good starting point would be to have him prepare a breakfast that did not require heating, eliminating Frank having to use a stove or hot liquids. Making the wife a bowl of cereal and a cup of juice would be a good alternative. As he progressed, meals that required more steps and more items and actual cooking could be incorporated. We would want to educate the hospital staff on how to best set up Frank's room. His items should be in a consistent arrangement, and ideally, items such as his bedside table, TV remote, call bell, and urinal would be positioned on his left so that he would be forced to turn his head to attend to that side. The prioritization of addressing his neurological deficits is that we would first address his left neglect due to needing to increase his safety awareness. Then we will work on his dressing apraxia, which would incorporate him having to work on his other cognitive deficits, including his impaired attention, judgment, and insight. Interventions we would use for reducing muscle tone in his trunk and upper extremity include NDT, prolonged stretch, positioning, orthosis fabrication, and potentially robotics. Here is a short video on the use of robotics for the treatment of increased muscle tone due to stroke.
Such as this stable flex device, which helps blood flow and also helps in preventing muscle atrophy. This device works well for patient Jennifer Saad, who has difficulty extending her fingers due to muscle tone.
So it's teaching her how to relax her tone and the stretch in her fingers, while also getting her to extend and open her fingers. Perfect.
Here, patient George Chrysantho wears a robotic mechanism with a triggering device that presses against his triceps and detects any activity in his muscle. If he should try to straighten his arm, the device will pick up that signal, and the machine will assist him in extending his arm a little further. Different exercises are used to employ this device. Kevin Malone is a former New York City firefighter who had a stroke one day while driving a fire truck. The purpose of Kevin's electronic device is that with the repetition of movement it creates, his muscles will begin to reconnect with the brain, and slowly, over time, may help allow him to make these movements on his own.
So for splinting recommendations, we suggest the use of a dynamic hand splint as well as a resting hand splint. The dynamic hand orthosis would be suggested, especially as Frank has a muscle tone of 2 on the MAS scale or the MAS scale, which indicates a marked increase in muscle tone. So the dynamic splinting will help to target the extensor muscles and forearm supination while keeping that thumb in abduction, all of which are needed for functional grasp and release. Also, his finger extension is weak and he's unable to release objects. So this would be a standard splint that can be used for Frank, especially as research shows that this is a recommended splint that is used for persons recovering from stroke and whom have hemiparetic hands. So the recommended wearing schedule would be to engage Frank in activities in repetitive task training activities for practicing grasp and release for 30 minutes, 3 times per day, for active digit and wrist motion, wherein he would rest every 2 minutes. And he would wear this at home 4 hours every day for 4 days for a period of 12 weeks. And we would measure his active range of motion weekly as well as use the MAS scale. For the functional resting hand orthosis, we would use this to help to position Frank's arm into a functional alignment for finger extension. Also, it would promote palmar abduction and extension of the MCP and IP joints. The recommended wearing schedule would be full-time, nightly, to maintain range of motion. Frank has perceptual and cognitive difficulties, such as decreased attention, poor insight, poor judgment, and poor self-awareness. He also has decreased figure ground discrimination, spatial relation difficulties, and profound left neglect. These would affect his daily functioning in many ways. He will have difficulty maneuvering within the environment due to his decreased or his impaired judgment and depth perception. He would also have difficulty locating items needed for self-care due to figure ground discrimination. He may also confuse his body parts and have a decreased self-awareness of his self-performance in activities. Functional activities for perceptual and cognitive difficulties. So the approaches that we would take would be a remedial approach as well as an adaptive approach. So for perceptual activities, the OT can engage Frank in either remedial or adaptive, as previously mentioned. So the OT can use multiple practice opportunities with a perceptual skill to produce carryover of performance to other activities. And then for cognitive activities, during functional activities such as dressing and grooming, the OT can use a variety of approaches such as the domain-specific training strategy. And this will teach Frank strategies to manage specific perceptual and or cognitive deficits, such as teaching him to use the iPad to help with his apraxia, especially in organizing his dressing tasks, and can help him to display, and the iPad can display photos and videos of dressing, and he will copy what he sees on the iPad. During rehab, the OT can use a variety of cues. She can use a combination of visual and verbal, as well as an hierarchy of cues where she would move from visual to verbal cueing. She can also use gestures. So she would say, show me how you put your pants on. Use the soap to wash. And he would demonstrate it. Or reach for the soap. And then the OT can also use gestures for imitation. So she can say, copy what I do. Show me how you would do so and so. Or use this object just to get an idea of how he performs the task and just to address his dressing apraxia. She can also place dressing items on the neglected side and have Frank reach for it, and also have him retrieve clothes from the closet with the clothes mostly placed on the left side of the closet for him to just get that scanning into process so he can find items on his left side. The OT can use her hands to help him to perform the task as well. She can encourage Frank also to verbally explain what he is doing for each step. And since Frank is unable to identify or discriminate the front from the back of his shirt, she can place a tape over the back of the clothing items when Frank is practicing donning of shirts. She can make environmental modifications and modify the environment or the occupation or just to augment social support. In using global strategy learning and awareness, Frank will be able to, this can help Frank to be aware of his cognitive processes and develop his own compensatory approaches, such as internal problem solving and internal reasoning. So, while he is moving around in his environment, he can scan the environment by turning his body to where the items are or to where the furnitures are to help to promote a greater sense of awareness. For occupation-based or preparatory interventions, we would address figure ground difficulties by having Frank sort, label, organize, or pick out items from the background. And these items can be specific towards his preferred activities. So he likes to garden and he likes woodworking. And so these can be related to his preferred tasks. We would also engage him in scanning activities where he would look at or identify pictures in a woodwork magazine and ensure to look throughout the book, so from left side to the right side of the book. We can also use strengthening and range of motion exercises. For preparatory methods, we can specifically use physical agent modalities such as hot packs to increase blood flow and decrease tissue tightness and pain. We can also engage him in manual activities that are related to his preferred tasks. We can place items on the left side during grooming and at mealtime and have him reach for them. And since he has left extremity weakness, we can encourage use of adaptive equipment. For safety concerns, He has issues with sensation and judgment. So we can use non-standardized testing, such as light touch, as well as for this stereognosis kit with items that are specifically known to Frank, and we can educate him on vision and the use of environment adaptation, and we can further assess for sensory impairment to see if sensory retraining is something that we might want to use. Also, for judgment, we can use the judgment of line orientation test, which assesses his visual perception. We can address visual spatial relations by adding color and contrast to help him to find objects. And we can also minimize distractions and clutter. For left neglect, we can assess with line bisection task and cancellation task and clock drawing tasks. We can also engage him in spontaneous drawing and visual search of preferred activities, as previously mentioned. For psychological support, we would provide parent and patient and caregiver education on severe recovery. Also, we will coach the caregiver to help to increase her self-efficacy. So we will coach her on specific tasks and skills, home modifications, and then we would engage him in a wellness promotion program by helping him to identify and establish a routine, a new routine for the new role that his new role. And also, finally, we would augment Frank's coping skills and resilience by helping him to accept his loss of skills. We would address his possible denial, and this may be due to his the fact that he has left-sided weakness, because since he is right-handed, then the stroke may not have such of a great effect on him, and he may not realize the seriousness of his lost skills. So we would help him to address his denial, and we would help him to set small, manageable goals. We will help him to personalize his rehabilitation, as well as managing any emotional challenges that he may encounter. For adaptations, we would ensure that the doorways or the entranceways are accessible. We would remove rugs, clear walkways, ensure adequate lighting, use taping. We will also ensure that the items are in reach and are stored consistently. Some adaptive equipment that we may use are grab bars, safety rails, rolly walker, reacher, etc. Necessity of assistive devices. Devices may be appropriate for Frank just to help him to perform his ADLs. Some of them that we can use are tablets, computer and electrical devices that will help him with his attention. Frank is very humorous, and we figure that this may be related to an indifference to the loss of his functionality, and it may just be a way that it may just be a strategy that he used to cope with his lost skills. Concerns of loss of function. We would we anticipate that Frank may be concerned about how he will return to hobbies independently, the length of time it may take him to return to his previous level of functioning, and whether or not outpatient or home health services are available for him. He may be also concerned about any exercise program that we can prescribe for him, as well as just alternate healthcare services.
Frank's problem list includes difficulty managing his clothing. He appears to have dressing apraxia. Difficulty with right and left discrimination. Difficulty maneuvering through his environment due to poor standing balance and his left neglect. He has poor attention span, orientation, judgment, and safety awareness. He has deficits in perception. More specifically, it's difficulty in figure ground and spatial relations. He has weakness in his left upper extremity and lower extremity. His finger flexion is within normal limits, but extension is weak, and he is unable to release objects. He has impaired coordination on left side for both fine and gross motor, and increased tone. He has a muscle tone of 2 on the Ashworth scale in his fingers and wrists throughout his upper extremity, neck, and trunk, and 1 in the Ashworth scale in his lower extremity. Frank's strengths include his finger flexion on the left side is within normal limits, so we can include some bimanual activity in our intervention plan because he is able to grasp. He has no active range of motion or sensory deficits in his right upper extremity, and he reports that he is right-handed, so we can teach him some one-handed techniques such as dressing. He can also use adaptive equipment with his right hand, such as a long-handed reacher or a rocker knife. He has good social support, so his wife can be included in a lot of the intervention planning because she is very supportive. He also has a positive attitude. Frank is amiable and likes the staff members. He teases them and is good at involving humor in interactions with others. This can help with motivation during our intervention plan. So Frank's wife will be his primary caregiver. His wife is very supportive of his goals and will do whatever it takes to get him home to live life as before. It doesn't specify whether she works or not, but it sounds like she'll be home with him most of the time. And his wife already does a lot of the meal preparation and laundry. He also has some good friends from work that he bowls with once a week, and he is friendly with some of his neighbors, so they could help with some yard work or housework or be there for any emergencies. We would like to include Frank's wife in all education sessions as she will be his primary caregiver. Frank is having trouble orienting himself to his situation and displays poor judgment and safety awareness, so it is especially important to educate and train his caregiver. An area of education we would like to provide to Frank and his wife includes a general overview of a CVA. We want Frank and his wife to understand what happens during a stroke, what body functions it may affect, and what to expect regarding progress and outcomes. Understanding their situation may help them set reasonable goals and better prepare for the future. Another area we would like to educate about are transfers. He currently transfers with minimum assistance with moderate verbal cueing because of poor safety awareness, so we would like to train his wife on assisting him with his transfers. We would also like to educate them about available adaptive equipment and how to use them, and dressing techniques using only one hand. As we mentioned, Frank appears to have dressing apraxia, so his wife will most likely need to assist him with all dressing. Now I'll go over some theories and frames of references that we could use with Frank. The first one is the PEO model, which is the Person, Environment, Occupation model. It states the characteristic of the person, environment, and the nature of actions, tasks, or roles are considered when trying to understand occupational performance. So for Frank, we can either alter his environment or parts of his tasks to provide a better occupational performance outcome. An example of this that I was thinking about was maybe moving his gardening stuff closer to his house, providing a sitting area while he does this, and moving all of his supplies to a lower cabinet so he can access everything easily. Another approach we can use is the biomechanical frame of reference. It states that improving strength, endurance, and structural integrity will lead to improved function. Frank is experiencing weakness in his upper and lower extremity on the left side and increased tone, and this will definitely affect his activities. He also states that he would like to travel, which usually includes a lot of long days of activity, a lot of walking around, and he states that he likes woodworking, which requires some strength and endurance for both. We could also use the rehabilitative frame of reference. Its aim is to increase independence by providing environmental adaptations and compensatory strategies. It considers the client's roles and the tasks the client considers essential for satisfactory performance of those roles. So using this frame of reference, we would work on applying the use of adaptive equipment into his occupations. Here are just some examples of gardening and bowling adaptive equipment. He stated that he'd like to get back to the two of those when he returns home, so we could work on some of those things. For Frank's neuromusculoskeletal deficits, we could use the neurodevelopmental treatment approach, also known as NDT. It believes that the brain is plastic and capable of new learning. Spasticity and hypotonia are the major barriers to normal movement, and it uses bilateral focus, positioning, handling, and sensory stimulation to facilitate normal movement patterns. There is evidence that NDT can improve gait, hand function, and ADLs in people who experienced a stroke. So these are some functional assessments to evaluate Frank's upper and lower extremity use. The first one is the Functional Independence Measure, also known as FIM. I chose FIM because it provides a uniform system to measure the level of disability, and it also indicates how much assistance Frank will need to carry out all of his ADLs. The next one is the Performance Assessment of Self-Care Skills, also known as PASS. PASS is a valid and reliable tool designed to measure occupational performance of daily life skills. It is client-centered and performance-based, and it includes ADLs and IADLs with a physical emphasis and also a cognitive emphasis. So this could definitely be useful for Frank because he appears to have a lot of cognitive deficits that are affecting his performance. And I also included the Bennett hand tool dexterity test because what's most important to Frank are his hobbies of gardening and woodworking, so we'd like to include the use of tools in this assessment, especially because he plans on focusing on these occupations when he returns home. The hand tool dexterity test can be used as a general assessment of an individual's skill in using ordinary mechanical tools. The results of the test have been used as an indicator of success for jobs or tasks that require the use of these or similar tools. So here are Frank's long-term goals. First one is by week 4, the patient will complete upper extremity dressing with minimal assistance. The other one is by week 4, the patient will demonstrate increased dynamic sitting balance at edge of bed for 10 minutes while participating in ADLs. I included the dressing goal because I want to increase Frank's independence as he returns home. And then I also included the dynamic sitting balance goal because this will come into play for a lot of Frank's hobbies that he finds important as he returns home. His short-term goals are by week 2, patient will complete upper extremity dressing with moderate assistance. And by week 2, patient will demonstrate increased dynamic sitting balance at edge of bed for 5 minutes while participating in ADLs. Frank's main goals were to return home and resume his hobbies. So I'd like to include this by creating an intervention plan that includes at least one of the tasks of gardening and woodworking. I think we could work on some tasks of gardening or woodworking while working on dynamic sitting balance. And I'd also just like to relate all of his therapy gains to his hobbies. So even dressing, we will be working with left-sided awareness, safety awareness, active range of motion, finger extension, and the use of adaptive equipment, which will all come into play with his hobbies and other occupations. Obstacles to reaching his goals might include some cognitive impairments. I'm thinking the main one would be his safety awareness and judgment, and then also his orientation to the situation. He's not completely understanding why he's in the hospital, so this may make it hard to stay motivated or stay focused on the task. And then also his motor impairments, such as increased tone, decreased coordination, and left-sided weakness. We're hoping to remediate some of these, but they might play a bigger factor and be an obstacle for reaching our goals.
As far as the CODA's role in all of this, for the evaluation, only the OTR can perform the initial evaluation. The OTA may collect the data for the assessment, however, the OTR is responsible for the accuracy of the data collected. For the intervention planning, only the OTR may initiate, develop, modify, or complete a plan of care. The OTA may help revise short-term goals, but the final decision always resides with the OTR. For the intervention session, the OTR may only delegate tasks that both the OTA and the OTR are in agreement with, that are within the competency level of the OTA. Some other standardized testing that we could do for Frank would be the Barthel Index of ADLs. This assessment was completed upon evaluation and could be used as a follow-up measure, and this measures functional independence in areas of personal care and mobility. We could also do the assessment of motor and process skills, or the AMPS, and this assesses motor and process skills and looks at their effect on the ability to perform ADLs and IADLs. We could also do Sammis-Weinstein monofilament testing. There was some sensation testing done at evaluation, which helped determine the impaired sensation for light touch and sharp dull, as well as the impaired stereognosis on his affected side, but we could always do the Sammis-Weinstein test for further testing for sensation. Frank has regained active range of motion of 15 degrees in all motions of his upper extremity. How would the intervention plan be modified? How would this affect his ability to use his upper extremity functionally during ADLs and other activities? So, with this gain 15 degrees, the intervention plan itself would not really change a whole lot. We would continue to encourage Frank to use his full range of motion when doing any activities. However, the plan itself would not change. So this extra range of motion would allow Frank to have more functional reach and will help aid him in completing his ADLs and doing all of his desired hobbies.
So in this scenario, we walk into Frank's room in the morning to help him with his ADLs and find him in bed with the rails up and his left leg is thrown over them and he's trying to climb out of bed. He already has one leg over the rail, and so what would we do and why? How would we help him in this unsafe situation? And so we would try to help him to bring his attention to what he is doing and to help him to understand why this is an unsafe situation, and provide awareness and educate him on bed mobility. So in doing so, we would provide step-by-step instructions and request a return demonstration by having Frank get back into bed and then transfer from supine to sit at edge of bed in a safe manner. He should do so by gripping the handrail and protecting the hemi-arm. And at the end, we're going to address upright positioning and wave shifting for scooting forward. In an OT intervention in the kitchen, Frank is making a cup of instant coffee. He turns on the stove and he gets the kettle and takes it to the sink to fill it up. However, after he starts the water, he notices a sponge and starts to clean up the area around the sink and outside of the cabinets, but he has forgotten the stove and the kettle and has left the water running for 5 minutes. So what do we think is the cause of this behavior, and how would we address it? So we think that the cause would be an effect of his right-sided stroke on his ability to pay attention, to recognize the things that he sees, hear, and just an effect on his overall awareness and judgment. So as an OT, we would start with using an hierarchy of prompts to help him to attend to the problem at hand, and then to help to bring his attention back to the initial task of making the coffee. We might engage him in a metacognitive process to help him to increase his safety awareness and just his overall self-regulation. Any adjustments that we make would be specifically to minimize the distractions. So Frank will only use what is needed, and he will work in a clear area. We may also make recommendations for him to use an alarm and an electric kettle. Frank is in the middle of a dressing task. He has been given a set of cards with the steps for dressing on them with good results. But Frank is not attending to the cards. He starts to get up to leave the room, but he's only wearing his boxers. So how would we redirect him? We would ask Frank to look at the cards and then look at himself in the mirror, look up and down at himself, and help him to identify whether he has missed any of the dressing steps. Have him identify the clothing items that are missing, and then have him organize the clothes according to the dressing sequence. Lay them out somewhere on the bed, maybe from left to right. And then finally, we can have him complete the dressing sequence in an appropriate manner. During a functional mobility, Frank has progressed to ambulating with a Hemi walker and supervision. However, he bumps into objects on his left side, such as the door, the bed, the frame, the dresser. So how would we address this during our intervention sessions? We would go about this by increasing Frank's awareness of his visual neglect. Without his awareness or comprehension of the neglect, he will continue to be unsafe in walking around in his environment. So we can use the mirror, or we can make adaptations to his environment, and we can use canning activities. We can use brightly colored tape or Velcro to outline the pathways in the room and have Frank identify things within the area. We will prompt him to look to the other side, which is the side of his neglect, and just have him scan across the room. And this will help him to eventually ambulate safely. Also, while working with Frank's wife, we can ask her to write words or make drawings on the left side of a dry erase board and have Frank copy them onto the right side of the board. We will also position him for increased stimulation and awareness of his neglected side.
Frank is being discharged home and requires supervision for dressing and bathing using his cue cards and equipment. He continues to be impulsive and has poor insight into his deficits, and the carryover of new learning requires frequent repetitions. He can use his left upper extremity to stabilize objects, but his gross and fine motor coordination are still poor. He continues to have left neglect and has difficulty compensating for it. We recommend that he now attend outpatient OT and PT. Discharge instructions will be provided to Frank's wife, as she will be acting as his caregiver. First off, we suggest she rearrange the home, checking for safety hazards such as rugs or cords he could trip on, and would have her install the additional recommended bathroom equipment. We would want her to look for ways that she could set up things so that Frank would have to visually scan areas, such as rearranging his favorite living room chair to the left side of the TV and having him sleep on the left side of the bed so that he would have to turn to the left to reach his bedside table. We would encourage her to always interact with Frank on his left side.